Today's topic is on interventional pain management. I don't want to dive too deep into it, rather, keep it more simple for our viewers to understand the basics and the foundations of interventional pain management. So, the first thing I want you to go and understand at this point is the concepts. Then we will go a little bit into the diagnosis and the common procedures that we do. And again, very important to know what patients do we treat and what patients do we refer to surgery. And then we will end up doing a review of a real case of scoliosis. Pain management is basically a combination of multiple factors. It's biopsychosocial problem. There is a psychological aspect, there is a behavioral factors, social factors, and biological factors. Now, intervention, what we do, what we alter is only the biological factors. The rest have also got a major role to play, and they also potentiate the pain in many ways. So let's understand what pain is. It's a combination of sensory and emotional experience. So understanding the pain pathway helps us understand pain in a better way. It starts with an injury. That's where the actual noxious stimulus gets converted into an electrical signal that goes along a sensory nerve and reaches the dorsal root ganglion into the horn, goes on to the opposite side to the contralateral side, and goes all the way up to the brain via spinothalamic tract, enters the thalamus, and then you see that it gets projected into sensory cortex. It also sends an offshoot to the other side, to the same side of injury. Now, there is a descending pathway. This is the modulation. Modulation, as in inhibitory signals go down to the point of entry. Modulation basically is like reducing the signal. If it's coming way too much, it tries to put brakes on it. So, modulation is an inbuilt painkiller mechanism. It's a very interesting thing that you should look up after the presentation. It just opens up a lot of discussion. So this is a cross section sort of axial cut of a spinal cord. You can see on the top, this is the dorsal. Dorsal is where the inputs come. Sensory information enters here. And then you have a lateral horn. Lateral horn is mostly autonomic. It goes out from here, joins the ventral root where you get the motor. Both of these join and become a mixed spinal nerve. Let's see neuroplasticity. Neuroplasticity is when you have extensive pain for a long period of time, it changes the wiring of your brain. Basically, the shape and the way the neurons interact with each other changes over a period of time. This is a sort of maladaptation, you could say. And most of these changes are seen in prefrontal cortex. Then you see it in insula and anterior cingulate gyrus. So this is a breakthrough in imaging technology that has led us to understand neuroplasticity is actually a phenomenon that is occurring. So how do you prevent this? Over a long time, we people have contemplated how to prevent this, and then we understood that TCAs and SNRIs, along with the traditional pain management, that is where you start with medications and interventions, you also start SNRIs in a way to modulate and reduce that pain so neuroplasticity can be prevented. So traditional pain management generally includes medications. Then you go to physiotherapy, lifestyle modification, surgery, and this is all pretty much intuitive at this point. The WHO analgesic ladder guides us of how judiciously we should use our analgesics. Always start with the most basic ones and then go towards weak opioids and strong opioids. Then let's understand what are minimally invasive procedures. We target the pain generators. A part of our practice mostly we spend time in identifying where the pain generator is. So each organ, for example, the spine has multiple areas from where the pain can come. It can come from the disc, it can come from the facets. There are multiple places. I have a slide to show you exactly that further down this presentation. The advantages are it's targeted and faster recovery being daycare. Most of these patients who come in for pain management, they are not admitted. They walk in, walk out time is almost under 2 to 4 hours. So we just keep them in the observation room just to see the vitals and then they're walking back home. That is the best part of pain management. So what are the conditions that we do? It's an obvious question. What we see mostly are lumbar radiculopathy, cervical region, then facet, then you have sacroiliac joint, osteoarthritis of the knee and shoulder. These are probably the maximum number of cases I've seen in my own personal practice. I could say most of our patients come with knee osteoarthritis and mostly in advanced state. And I've seen quite a number of plantar fasciitis as well. Now, most of these conditions can be done in ultrasound, but I prefer doing it in fluoroscopy. Those are the spinal procedures. So that's when the game changes. So common procedures we do, Again, steroid injections, epidural steroid injections are the game changer in chronic pain coming from the spine. Then you have facet injections, medial branch blocks, and RFA. We target the medial branches, and first we do a diagnostic block and then go to a radiofrequency ablation. Nerve blocks are obviously there. We also do a bunch of golfer's elbow and tennis elbows. I've done a few wrist injections as well in the carpal tunnel, and joint injections. Those are basically bread and butter for you. Here's a video where I am doing genicular nerve block. Now I'm scanning the bone using an ultrasound, and you can see the edge of the bone here. The tip of the needle is seen over here. The movement in the tissue is not seen every single time, but you have to move around the probe to find the tip. And it's also out of the plane. And so it is really difficult. You get to do this after a bit of practice, but you can still appreciate over here. The midline here on the screen coincides with the midline on the probe. Here's another one. In this procedure, I have inserted a spinal needle inside the knee joint, suprapatellar approach. This is the needle inside the joint. And this is how we aspirated the fluid. Once you have the needle positioned in the right space, you can start aspirating and you can check again to see if the needle is in the same place. Now, image guidance, C-arm guidance, there is a concept called ALARP, as low as reasonably possible. That's a concept where we try to reduce the exposure to radiation as much as possible. So as you get to learn your landmarks better and patient positioning, the number of shots that you take with the C-arm should significantly come down. So I always have one attender or somebody, a staff inside the OR, clicking on a clicker the number of shots that I'm taking so that I keep a track of how many shots I've taken as opposed to the last time. It's like something that I like to put on a leaderboard. Every single time I've done a similar case, I always look at the number. Lower the better. But then the whole world is moving towards ultrasound. So this is the era of the ultrasound. So most of the procedures are now cleared for ultrasonography, except the spine, I would say. And then CT guided interventions are also there, but usually they're not used. Here's how we use the C-arm for knee injection. I'm taking a lateral scan over here and injecting a viscosupplementation. And on the screen, you have confirmation of the same. Let's get on to our case, angulostetal or angles of pain. You must be aware that the degree of scoliosis can be done using the COPS angle, the angle of the end plates that you take, and then the angle that you get on the screen. This is the COPS angle that shows the severity. Now, in our particular patient, she's an 85-year-old, frail, low physiological reserve, and non-diabetic, non-hypertensive, fortunately for us, and no prior spine surgeries as well. She had presented with low back ache, with lower limb radiculopathy for 6 months plus, almost 8 months, in fact. And progressively, it was getting worse. And she also had claudication. She was walking for about 10 to 20 meters. She was getting pain. And the pain was lateralized, mostly radiating to the lower limbs. It was mostly to the left side. And visual analog scale, you get an 8 to 9 exacerbated by standing and neurogenic claudication pattern mostly. And this was a very classical thing that it got relieved on sitting and forward flexion. Now, this shows that there is some form of compression here and poor response to medication and physiotherapy. She went to almost 20, 30 sessions of physiotherapy and she was fed up with treatment as such. And most of the surgeons didn't want to operate on her because her physiological reserve, as it is, was low. And you know the changes of the lung in scoliosis. The whole vital capacity and everything gets reduced, and they're not very good candidates for ventilation as such. So claudication, as you can see, less than 20 meters, she had to sit down and walk again and required support. So spine examination also revealed lumbar scoliosis, restricted extension, and right leg raise test bilaterally positive at 30 to 40. Left one was even more severe. It was around 30 degrees and pain got really bad after that. And then sensory also got diminished a little bit and reduced ankle jerks. Fortunately for us, there was no bowel and bladder movements involved. Like these are the red flags that we see. If there are any changes, incontinence, that is a red flag. That's when you have to refer for surgery. So this is always rule of thumb for all pain management specialists that we look for red flags first. Only then you proceed in doing a procedure. We did an MRI, of course. AP examination is not always enough for us. And also, there are multi level involvement. So, you might as well want to get an MRI done and understand where the compression is. Now, that revealed a L45 region central disc protrusion with severe facet arthropathy and canal stenosis. So, I always write in my requisition form to give me the AP diameters. So, I understand where the maximum compression is and where the stenosis is the maximum. So where if you want to plan a single shot, for example, you cannot give more than 80 milligrams of a steroid in a patient. So you have limited resources that way. You can't distribute, keep on giving 40-40 at every level. So you might as well decide where you want to do it, and that better be the location where the maximum compression is at. So that becomes really important when you write a requisition. Now, critical lumbar stenosis is at L45. So I was logged in on L45. And since she was a poor surgical candidate, this is where I decided to go ahead with my procedure. Now, this is not a routine transforaminal that I did because generally patients have a straight spine, the landmarks are good, and you see where you know where you're going with your needle sort of on the C-arm. But we faced a lot of trouble. I'll come to that. Now, the choice of intervention, I was actually thinking between two caudal epidural and transforaminal epidural steroid. In the coming two slides, I will explain you why I chose transforaminal epidural steroid injection. Now, that was governed specifically by laterality. When you have bilateral symptoms and when you have a compression canal stenosis, you might want to do a caudal epidural. But if it's more lateralized, then transforaminal epidural steroid targets a nerve root, a specific nerve root. So this becomes an obvious choice. Pain generators, like I was talking about before, there are multiple regions like the disc here. Disc can be compressing onto the nerve roots. That can become a pain generator. The disc itself being ruptured, the annulus being ruptured, that becomes a pain generator. More autonomic kind of pain pattern. Then you have bone, obviously the bone fracture. Vertebral body fractures are very common in older patients. And joints, again, facet arthropathy, the joints can generate pain. So that's when we do a medial branch block. And you have ligaments. Of course, the ligaments here, the interspinous and supraspinous ligaments that can take a toll, then paraspinal muscles and nerve root, of course. So foraminal and lateral recess stenosis was also seen in this patient. So we did analysis and then we finally understood that it is radicular predominant, meaning there is compression of the nerve root. Radiculopathy, neuropathy, and myelopathy. I want you to take a snapshot of this section and go through. This is more theoretical, and this is very important for you to know the differences between each of these. I will not go into this because it gets more theoretical. I want to give you more of a practical aspects of pain management here. So kindly go through this. Lumbar radiculopathy. Now, that's when lumbar radiculopathy is a term used when the nerves, the exiting nerves that come out of the foramina get pinched at the level of the spine. That's a radiculopathy by definition. So it's a common indication for epidural injections. Why does it happen? Disc herniation, foraminal stenosis. Like in our patient, we have almost sort of both. When you look at the film, which I don't have here, unfortunately, you could see that it's very much compressing the thecal sac and it's going beyond and touching and pressing onto the nerve roots. So what she had was radiating pain and numbness and weakness for over 8 months. So it is a clear diagnosis of lumbar radiculopathy. There are different types of epidural steroid injections. Now, one on the left of your screen is caudal epidural. The ease of doing caudal epidural is the best, actually. It is the one of the easiest procedures that you can do. You, in fact, don't even need image guidance in most cases, but it is good. The problem with that is 30 to 40 ml. There's a significant volume involved in this. And in this frail patient, she was also not too tall. I didn't want to give too much of fluid to her and risk her hemodynamic parameters. So I shifted from a caudal, I went towards interlaminar. Even that interlaminar was not a good choice because of laterality. So I even omitted interlaminar here and then went for a transforaminal, which has the least amount of injection fluid. Injectate is the least 2 to 4 ml. You're done with that. it spreads along the dural sheath and it gives you the procedure, the amount of satisfaction that you want, and the amount of pain relief is maximal. It's also because I'll show you why it is very targeted. Here is a lateral view of the foramen. The one on the bottom is like a magnified version of the same foramen. You can see where we want to go is basically under the pedicle. This is the pedicle region. You can see it is labeled. So our landmark is subpedicular. You want to go below the pedicle and your tip of the needle should be over here. And here you see in yellow is the nerve root, basically. And around this is the dural sheath. So your tip of the needle should be on the dural sheath and not puncture the nerve root. So there are steps in getting here. Basically, you start, I'll show you how we do that. So you need to position your patient on the C-arm. Patient is prone and you get the C-arm on top of them. And I'll show you, this is a 3D version of what we are doing. Now you get a desired level, that is L4. Then you rotate the C-arm to the side of injection. Then you identify the pedicle and then go subpedicle at 6 o'clock position to the pedicle. That's where the nerve root is exiting, like I just mentioned. But the real images are very different from what you're seeing here. This is how it looks like. So the first one on the left side is a real image, a real fluoroscopic image of the patient lying in prone position, and we took a shot. This is the L4, L5. Now I'll show you the landmarks here. This is the pedicle. Now it has become 2D. Basically, it's projecting towards the camera, but it's sort of flattened out, and all you can see is the boundary of it. So you see this is the pedicle, this is also a pedicle, and this is your spinous process. The first step is getting these two in equal distance. This is called as a true AP. True AP view is the first step. The second step is getting the end plates of the desired vertebra where you want to do the injection, basically the procedure. The end plates have to be parallel. They have to, since it is like a disc, if it is kind of tilted, you will see a cylinder-like appearance here. You basically want those two leveled at the same. So this becomes a straight line. So in this image, pretty much the end plates are straight. The distance between these two is straight. So this is a good true AP and it is also blocked. Next, we do an oblique. You go oblique towards the side of the injection, basically in this left. So you see the pedicles over here. There's superior articular process and inferior articular process here. This is the facet joint. And this is where we would want to go if this was L3. So we wanted to do L4 and 5. So we went 6 o'clock position to the pedicle of the desired side. That's where we injected our dye and we got the desired spread. Now the challenges in the spine was degenerative changes of, again, foraminal narrowing and scoliosis, of course. So it wasn't straightforward. Generally, we get C-arm exactly 90 degrees to the patient. And in this case, we had to rotate it to the axis of the desired vertebra. So it went almost diagonal to the patient. Chronic lumbar radiculopathy, severe scoliosis, and failed medication becomes an automatic case for transforaminal epidural steroid. I hope you got a little bit of idea of what pain management is all about. Basically, I use the example of my most difficult cases that I've done. Generally, it's not that difficult. You do knees on most cases, then you do shoulder hydrodilation. Maybe in the coming videos, we could cover one shoulder hydrodilation where I can show you a real life example, how we go about the different steps in doing hydrodilation and also suprascapular nerve block. So procedure strategies are very important, careful fluoroscopic planning and getting all the views, like I said before, and the outcomes are generally good. And the key takeaways here are proper patient selection is always the most important step, in my opinion, in my own practice. I've gone by this, and anatomy needs to be understood properly. And if you have any questions right now, feel free to ask me, and I'll do my best to answer them for you.